First and foremost, thank you from Community Health Partners for Sustainability. Again, for the folks who haven't met me yet, I'm Alex Lair-O'Connell, Director of Community Health Partners for Sustainability, and of course from the National Center for Health and Public Housing in Astral. Welcome, thank you for the folks who are new today. We hope that you'll get a chance to meet all of us, and we hope you enjoy the session. A couple very brief housekeeping notes, and then I'll turn it over to our great panel this morning. For folks interested in the site visit, so we're going to take a site visit to the newest funded FQHC here in Denver, Sheridan Health Services. If you're interested, it's okay if you didn't sign up or anything. We'll have a bus taking people there. The bus will leave promptly at noon. So if you're interested, just meet me by the registration desk right outside there. And we'll head over. Again, we're going to leave right at noon so that we can be back no later than 3. I would say if you have a flight that you're worried about missing, don't risk it. But we would love to have you see that health center. Second of all, to remind you, all the presentations from the breakout sessions, the slides, recordings, all of that kind of thing, we'll be putting up on our websites shortly. And you'll certainly get an email when that material is available. One other thing, in your folders, remember there is the overall conference evaluation. We really hope that you'll take a minute at some point today and fill that out and turn it in to anybody with a staff ribbon, or just turn it in at the registration desk. That is our way of refining the work that we do, making sure that these events really meet your needs. I mean, you're gracious enough to take time out of your busy schedule serving your communities to come here. The least we can do is make it an effective session. The only way we can ensure that is if you tell us what you'd like to see done differently, that kind of thing. And finally, just to emphasize that, especially for the folks that are new, that are meeting us for the first time, this is not the end of our relationship, I hope. This is a small part of the work that the National Center for Health and Public Housing and Community Health Partners does. We're here for you 24/7, 365. So as you encounter challenges, as you come up with ideas, we hope you'll be in communication with us. We're your conduit to get the assistance you need, and also we're your spotlight and microphone to shine national attention on the great work that you're doing and your innovative ideas. So again, please be in contact with us. So with that having been said, I'm happy to introduce Shawn Frick, who comes to us from the National Association of Community Health Centers. He has an extensive career with Federally Qualified Health Center program. He arrived at NAC in 2010 as the Associate Vice President of Primary Care Association and Network Relations. He supports primary care associations and networks in implementing consistent strategies for strengthening and expanding health centers all across the country. He currently focuses on implementation of the Affordable Care Act, and there really, to my knowledge, is no better person who understands all the ramifications for consumers and for health centers of the Affordable Care Act. So I hope you'll join me in welcoming Shawn.
Thank you. I just told Alex I think he just way oversold that, because I don't know anybody that knows the Affordable Care Act very well. Let's see here. Thank you, everyone, for having me, for inviting me. This is actually my second time to be able to come to a public housing conference, and I really appreciate the opportunity. I love going out to the field and meeting the health center, the people who are running the health centers, public housing health centers. It is always refreshing. I was previously the CEO of the Ohio Association of Community Health Centers, and I saw my members every single day. I could travel throughout the state of Ohio and never more than 25 or 30 miles from a health center. Now, when I'm in DC now, I feel like I'm a million miles away from the health center. So it's always good to be able to come out and meet everybody and see what's going on really in the field on a daily basis. So I appreciate the time here. So, I think that this slide, more than anything else, captures the situation that we're in. First of all, I'm from DC, and I'm here to help you, if you believe that. These two things happened over the last couple of months, and my life has been, our life at NAC, the lives of the PCA, staff as well as the community health center staff has been absolutely been turned upside down over the last couple of months, really, since some rules started coming from CMS and some other things that have happened. So if I'm sure everybody's heard of the train wreck comment, this is actually what he actually said. He said, Senator Max Baucus said this to Catherine Sebelius. I just tell you, I just see a huge train wreck coming. I don't have that opinion. I think actually we're doing just fine. Some decisions are coming down that may not be what we wanted, but we're still moving forward. The Affordable Care Act is still the greatest thing that happened for healthcare in the last 30, 40 years since Medicaid, since Medicare was passed. So I'm very, very optimistic that we're going to get this thing done. That's not to say we don't have a lot of work to do. But I do think the next thing is personally my favorite. On May 16th, the House GOP rejoices to vote to repeal Obamacare, and Democrats see insanity. Does anybody know how many times the GOP has voted to repeal the Affordable Care Act since it was passed? Once? Twice? How many thinks it was 5 times or more? How many thinks it was 10 times or more? 15? Anybody know the answer? 37 times. I'm not a very smart guy, but I don't think they like the Affordable Care Act. I'm going to go out on a limb there and say that. So obviously we have one side of the aisle who definitely is in full-bore implementation mode, and then we have the other side of the aisle who wants nothing to do with this. Regardless, it is going to happen. It is going to be fully implemented on January 1. I shouldn't say fully implemented. We actually start seeing patients on January 1. I think that we've got several years of implementation ahead of us, and that's critical that we understand that there's a tremendous amount of work that needs to be done right now, and I mean immediately. But that work is going to be ongoing, basically, I would say for the next 18 months in terms of healthcare operations, and I'll get to that in just a couple of minutes. This is basically what I was planning on talking about today, appropriations. So you guys have an idea of what's actually happening, both what has just happened, the budget that we're working under right now, as well as what we're planning for 2014. Don't forget the trust fund still does exist, the Community Health Center Trust Fund. $11 billion was set aside for that, and we are actually just coming upon some of the huge numbers that have been set aside for that. We're going to talk about essential community providers, qualified health plans, I apologize for the misspelling there, and outreach and enrollment. Some things are happening, everything is happening right there between the ECPs, the qualified health plans, and outreach and enrollment. That's where all the action is taking place. And then 2014 and beyond. So where we're at right now in terms of appropriations, we did get basically level funding for the Community Health Center program, plus $300 million though, from the trust fund. So we got our base grant appropriations that we've had over the last couple of years, plus the additional $300 million that we got from the trust fund. Now, how this actually breaks down, first of all, sequester did impact the community health centers. It didn't impact you on an operational level, but it did impact the program because we did have to take a $112 million hit. And if you add up these numbers, you will quickly realize that 112, 48, 19, and 150 does not equal 300 million. I'm not a math major, but I figured that out pretty quickly. The $48 million from base grant adjustments will be coming probably sometime in August. The new access point funding will take place sometime around August as well. They are sticking to the original president's budget of spending about $19 million for 25 health centers. The good news about this, and there's always been sort of a question about how new access point applications are received and how long they're viable and for, because it has changed over the years. We expect the announcements to be made sometime in August. On the date of that announcement, from 1 year from that date, the applications that were received will be viable. From what we understand, there were about 400 applications that were received. Typically, in a normal application process, about 10% is going to get kicked out for technical reasons. Something was wrong with the application, so we're probably down to around 375, somewhere between 350 and 375. Like I said, 25 will be funded, and then those remaining 325 to 350 will be viable for another year. And so that's very, very important. Obviously, the biggest amount of money coming forward is the $150 million from outreach and enrollment. As I said, part of that money certainly came from the trust fund, and part of that money, I don't really know where it came from. My guess, it might have come from CMS, but if you add those numbers up, it does not equal $300 million. So we got some money coming probably from CMS would be my guess. For 14, and unfortunately, we're in this situation with the way politics are these days. no budget. They never pass budgets on time. I'm sure at the end of the year, end of the fiscal year, we'll be looking at a continuing resolution again. We'll go through probably pass through the new year and probably have a budget sometime around January, February. The fiscal year 2014 Affordable Community Health Center Trust Fund, actually, we really start getting into the big numbers. Fiscal year 14, we actually are set aside $700 million. That is a significant amount of money, and it will be something that will certainly be on the minds of both the Republicans and the Democrats moving forward. I can tell you that we have already we're already beginning conversations with the administration and with Capitol Hill on this. We definitely want to see, NAC is pushing very, very hard that the majority of that money go to existing health centers. We're thinking about doing so. We were really hoping that we'd do some things a little bit different this time around, as opposed to just having a new access point, where there might actually be an opportunity for you to take that money. If you're an existing grantee, I assume everybody's an existing grantee out there? Most of everybody should be out there? Okay, great. Actually, maybe going after, if there's an opportunity for funding, you might be given a menu of options. Sort of similar to what was done when ERA funding came through first. You have an option, whether you want to do a new access point, if you have a new community that you'd like to reach out to, or you'd like to expand capacity, or you'd like to do a service expansion. That's what we're really pushing for. Once again, focusing the money that we have available to the existing health centers. We all know that building a health center is not easy, and it's taking a long time to get these get the newer health centers, the ones that are 5 years old or less, up to speed. And quite frankly, there are some significant operational issues with those new health centers that are very hard to overcome. So that is definitely the direction that we're looking for this year. So moving on directly to the Affordable Care Act, I'm sure everybody has seen a version of this illustration here, where I'm going to focus my next couple of points is in the bottom left-hand corner in terms of the qualified health plans. This has been our biggest obstacle over the last several months in terms of the way qualified health plans are doing business, who they're doing business with, and their strategies that they're using. Right now, this is currently what we know. 17 states and DC are doing state-based exchanges, meaning they're running their own thing. 26 federally facilitated exchanges, meaning the states have said to the federal government, you run my exchange. And then we have 7 state partnership models right now. CMS just announced, I think it was last week, 120 insurers have applied to be community health or qualified health plans, and everybody knows these 2 dates. October 1st, 2013, initial enrollment begins, and then January 1, the show begins with coverage beginning. So, in terms of Medicaid expansion, we're still under the same situation as a result of the Supreme Court decision of last year. States are not required to expand Medicaid. I still believe that, and they can do so without penalty, I still believe that we're going to see almost every single state will take it over in the next couple of years. I've got it listed as 25 states say they're expanding, 25 say they're no or a maybe. This is a major issue for health centers in the no or maybe states. Even those states that are no's, I expect them to come around in the next couple of years, but I expect them probably to go with an Arkansas's model. Is everybody familiar with what's happening in Arkansas? Okay. It's complicated, but I'll try to simplify it as much as I can. The state of Arkansas basically went to CMS and said, we don't want to expand Medicaid, but we do want to take the money and we want to basically create a larger exchange market. Does that make sense? It's a pretty simple concept, but when you get into the weeds, it gets really, really complicated, really complicated. The number one thing is that these are still Medicaid patients. So they do have rights in regard to, for you, you have a right to PPS payment for a Medicaid patient. But there's nothing that would require the community health, the plans to actually contract with you. So that we have a combination of different things going on. Now, I can tell you that Arkansas has not submitted any paperwork yet that we are aware of. So we're a long way to go on this. But that Arkansas model, CMS has said that they're willing to consider it. And I expect that if they get something that is palatable to them, I expect a lot of states that are in that no column will probably go in that direction and will probably try to do something like that. If you are in one of those 26 or 25 no or maybe states, it would be very wise to follow what's going on with Arkansas, because it might be a very strong indicator of what's actually going on. I can hardly see this on here. If everybody's going to get a copy of this, but if you go to that link, there is our most recent issue brief on this Medicaid expansion target. It will explain everything about what's going on with what's currently known about Arkansas, and hopefully it'll be helpful for you. Essential community providers. I think everybody's aware of this situation. When the rules came out, NAC was very, very upset. In our opinion, does not follow the letter of the law in terms of what the Affordable Care Act states, but unfortunately, qualified health plans are not required to contract with every single community health center. 20% is the initial threshold, can get all the way down to 10% depending on how the QHPs actually define what a community or what a safety net provider is. That is very, very important. If they say that a particular provider of care is actually a safety net provider, CMS is probably going to allow it. So if you absolutely need to know in your state who is on the essential community provider list. Obviously, make sure you are on that list, and then most importantly, you need to reach out to the qualified health plans when they identify themselves. I realize there are some states that you really have no idea who they are at this point, but it's incredibly important that that is done so. And then on the bottom of this is another issue brief that we just brought out regarding this issue as well as PPS. Unfortunately, PPS is not a guarantee under the Affordable Care Act. Not only are you not guaranteed PPS, you are not guaranteed a contract. So it is very, very important that we start focusing on the way that the managed care plans are actually thinking about this, because they really are in the driver's seat at this point. Now, it's not to say it's not going to change, especially this ECP rule. There has been a lot of complaints about this, and we do expect maybe something will change over the next couple, maybe probably next year, but I can tell you for this year, I don't see CMS making any changes whatsoever. So, show of hands. How many health centers in this room have been contacted by QHP? Wow. I'm seeing about maybe a dozen. Unfortunately, that's what we're seeing across the country. Now, that doesn't mean you're not going to get contacted, because obviously the QHPs just did apply, so we're still in a situation where they're still building their actual networks. But I can tell you, we just finished up an assessment of 41 states. While we got some good information, the most important thing is the 39%, is that basically 40% of the states are reporting little or no interaction whatsoever with QHPs, and that is very, very discouraging. If we're trying to be a part of the Affordable Care Act, we absolutely have to have contracts moving forward. So I'm not going to spend a whole lot of time on this, but you can clearly see that the QHPs that have contacted the health centers, it's generally been a take it or leave it attitude in terms of, this is my contract that I'm offering you. Either you accept it or you can leave it behind. Very few are getting PPS. All products provisions, this is critically important. All of those contracts that you have signed over the career or life of your health center that are still viable, please read them. It is critically important that you see what is in those contracts. Several states have a prohibition against what they call an all products clause. But essentially what an all products clause is that it essentially says, it's something in the contract that you have right now that says the QH, or the health insurance company has the right to offer you a contract for a service that has not yet been created, and you are required to accept the terms of the agreement under the previous contract. So they effectively will simply send you a letter saying, we're having a plan set up for, we have a contract to be a QHP, you are part of our network. Either you accept it or you don't. And that's what we're going to, I think we're going to see that quite a bit moving forward. So understand how the QHPs are thinking is critically important, and I'm running out of time here quickly, so I'm going to try to go through this quickly. They look at things either from two different perspectives. If you're a qualified health plan and you have you can look at this from two different perspectives. Either a Medicaid churn product, which would basically our patients churning from the exchange to the Medicaid and back and forth, or you can look at it from a completely different perspective, from the small business individual marketplace. Those are two diametrically opposed conversations. Over here, the small business and individual, 95% of the time, they don't even know what a community health center is, have no idea what we are. And so that's why one of the reasons you're not getting contacted by your QHPs right there. Over here, the Medicaid managed care plans, they generally obviously do know who we are and they are working with us. But most big companies are taking the commercial small business perspective on this. And so that side of the company is running it and they don't have a good understanding of what we do. Another thing is most of the Medicaid managed care plans that are out there, the big boys, are not going to get involved with this in 2014. You talk to Centene, Aetna, United, they are not going to get involved with this thing because they feel there's too many chronically ill that are going to be in the marketplace immediately, and they're going to wait for the rates to normalize a little bit to where they can actually make a profit. I'm going to try to go through this a little bit quicker. So as a result of that, what do we need to do? We need to understand how the managed care plans do business. And they when we talk about patients, they mean enrollees. It's all about enrollees for them because it's a business for them. They are certainly there to help build communities, but their first and foremost goal is to make money for their shareholders. Learn to understand how to talk their language. It does not matter what level of risk you're willing to take if you're going to get involved with an ACO, even potentially getting involved in larger for-profit entities. You must understand your data. Coding issues are going to be huge. These qualified health plans, it's going to be different than Medicaid managed care that you see across the country. Qualified health plans are all about coding. If you don't code correctly, they're not going to see you as a good partner. If they don't see you as a good partner, you could potentially lose your contract. And that is the reason why a lot of health centers right now are not getting contracts, because they have historical data on community health centers from across the country, and they say, well, you know what? I don't think that they're a good bet to put these people into because they don't code correct, or they're not showing they're a good quality provider of care, and that's a big issue for us. This has been an ongoing, coding has been an ongoing issue for community health centers for a long time, and it's only going to get worse unless we address it sooner rather than later. Navigator, real quickly on the Navigator and outreach and enrollment, obviously as you can see here, $50 million was set aside for the Navigator grants, and then a month or two later, the CHC outreach and enrollment grant came out, $150 million. While obviously the outreach and enrollment grants were set up to be complementary. When you're talking about $150 million, clearly the community health centers are the drivers of the outreach and enrollment for the entire Affordable Care Act. So it is critically important that you work with your community partners. For us to be successful, once again, it's going to come down to data. Finding out, reaching out, in-reach and outreach to your existing patients, as well as reaching out to new health center or new patients in the community, making sure that they are aware of what their options are. And we do hope that some money may be coming down for the PCAs as well, so they can actually kind of start to coordinate this. Obviously, Enrolled America is there at a state level, but we need to get more. There needs to be more coordination at the state and the local levels as well. So I think this is sort of an illustration of what's really going to happen if you don't have a contract this year. Like I said, I actually see 2014 as sort of a dress rehearsal. It's a dress rehearsal. Everybody, it's all the money is on the table, but I don't see it as it's not absolutely critical you have a contract right now. But in 12 to 14 months, you better have a contract, or I think this scenario might actually come up. All the QHP enrollees are going to go to health centers that have a contract, and those health centers that do not have a contract are actually going to end up with more uninsured. You probably didn't get a contract because you probably weren't doing something right operationally, and more uninsured patients is definitely not going to help your case. So it's critically important. As I said, it's a dress rehearsal, but the mission does not change. We continue to always reach out to more communities and do the work that we are that we were built to do. If you're in a state that is looking to expand Medicaid, keep the push going forward. That is the most important thing about the Affordable Care Act for us, is that the states expand Medicaid. Engage your community board. I can't tell you how important that is. Obviously, this is an entirely different conversation than the traditional 19 program requirements. This is a full-blown managed care, high intensity healthcare delivery system now, and they must understand what we're trying to accomplish, and they must be drivers of that. I think I'm about out of time here, so and like I said, the quality, efficient systems are going to dictate your future. And NAC is going to stand by. We're doing everything we can, completely redoing our training and technical assistance to make sure that we are there, working with the PCAs. PCAs have to be drivers of this, and It is going to be critical really over the next 6 months to develop your plans, and over the next 12 months to actually implement those plans. Thank you. You got this under control?
Yes, I do. Thank you. I would like to thank Shawn Frick for that information. I think it's really important, as always, for our health centers to hear from NAC and really understand what's coming forward. So we will do our part to make sure that you get the information shared with you as these changes occur. So I would like to, without further ado, introduce our next speaker. This is Mr. Patrick Gillies, who is the current Regional Administrator for the Health Services and Resources Administration, coordinating operations in the Denver regions. Patrick has passionately assisted underserved communities and has helped forge a brighter future for those in need of critical health care services since 1997. So we'd like to invite him now to speak. Thank you.
Are they just, is this just going to roll to us? No, it's not. Are they on here?
They should be.
This is the part where you mess with the slides, right?
Sorry, I'm not sure. They're not controlling it from behind. Excuse me a second. Is this it?
So like you needed to fall asleep while we were doing the slides, right? We're here first thing in the morning. That was quicker than I thought. So I'm Patrick Gillies. I'm the Regional Administrator for HRSA here in Region 8, which covers North Dakota, South Dakota, Montana, Wyoming, Utah, and Colorado. I didn't miss one, right? My states don't like it if I miss one. And so on behalf of Dr. Wakefield, Jim McCrae, welcome for coming out here. Certainly Shawn gives examples of places where, the health centers are HRSA's biggest programs, and you have a lot of support from HRSA, and we're doing a lot to look out for you. And we're going to go fairly quickly through some conversations about the Affordable Care Act, because it's the biggest thing my piece of HRSA talks about. It's the biggest thing almost all of HRSA talks about. So very quickly, I'm going to talk to you about some of the things we've achieved already. I think some of these things sort of get lost in the shuffle. What's ahead, some quick comments about the marketplace and expansion. He covered some of those things, so I'm going to blow through that pretty quick. Some things about outreach, some you know, some you may just be discovering. And then probably most importantly, some resources and some conversations about what we want from you around these things. So I think you're starting to hear some of that. I think one of the things we're noticing is we're saying it to you so much, it's hard to kind of hear through the noise of like, what do I really need to listen to, what do I really need to do. So the Affordable Care Act. I was talking to a health center director, and the person said, well, after this Affordable Care Act gets fully implemented completely in 2016, you won't need us anymore. And I thought, then why did we put $11 billion into a bill for something we weren't going to need? So if you're wondering what the administration and what Congress at the time's expectations were around health centers, they weren't going to fund something. This is larger than HRSA's annual budget by a significant amount. The key is we expected the health centers to be a keystone in the approach in the Affordable Health Care Act, that care in the community through the primary care medical home models that you're establishing, with the comprehensive level of care, with the focus on primary care. That's what we want healthcare to look like. And the health centers we see as being a key component of making that happen. And we don't think it can happen without you. So we'll continue to support you and try to bring you along the path with us. When we're talking about now, the number we're using now is technically 19.5 million. The numbers we're looking at, that number is going to go up another pretty good jump. Just a couple years ago, we talked about 18 million. So you continue to become a greater and greater part of the communities we serve, and we appreciate that. We've done some things in some other programs as well, $1.5 billion in 5 years for maternal and child health, mainly for the home visitation program. We expanded the National Health Service Corps by about 3 times, so now we have 10,000 clinicians in the National Health Service Corps. Hopefully, those of you who are in areas with HPSAs were able to take advantage of those things. You know, a couple years ago, the end of the year would come and we would have open slots for National Health Service Corps that hadn't been funded. Now, if you don't apply at the deadline, you don't get in. So that program has really been revitalized and is almost starting to look like the Peace Corps for doctors within our own borders and territories. So really proud about that. And you know, by 2015, we'll have an additional 500 primary care physicians, 600 primary care advanced practice nurses, 600 PAs, and 200 more mental and behavioral health professionals with the things we're doing around the health professions and training program. So a lot has happened. I will make a note that, you know, a lot of people talk about, and certainly Senator Baucus had comments about, you know, you're not doing enough. So 90% of the policy side of the Affordable Care Act is done. And if you look at the timelines that we have, what we were sort of criticized for was we weren't talking to the public enough. Well, we're talking to the public a lot in the past couple years, but we're really at that open to the public conversation point. We want people to start doing something in October. So what's been happening is all the systems have been built in the background. CMS said they're at their 3rd level of testing early in a meeting we were at earlier this week. So all those electronic systems to sign people up and things are really starting to work very well. If you want to see a good example of that, I don't know if you guys have looked at coveredca.com, which is California's exchange. Very interesting website. You can actually go on there and say, if I make this much money and I'm this old and my kids are this old, how much do I pay, how much is the subsidy, and how much is the total cost? It compares plans. As a state, they kind of leapt forward with their website, and you can really see how far things have progressed in terms of the policies being solidified enough that we can actually put things on websites to tell real people how much they're going to pay. So what's ahead? I talked about the important role that HRSA grantees are playing, and that we're really looking to you by October 1st to be ready to start signing people up to the exchanges, whether the federal government is operating them or whether the states are doing the marketplaces themselves. You know, there's probably a mixture in the room, but with 25 of these things happening on the federal side, I can tell you people are working all day and all night on this stuff. We will be making these deadlines. We're going to be ready for you. This is just a quick kind of shot of where these folks are. I think it's kind of interesting where the little blank spots are, which means there's not as many uninsured folks receiving in need of services. But a lot of you can see that there's not very many places where no one needs anything. And an unshaded spot could be 10%, right? So that's a pretty high number in terms of who we're talking about getting to. Medicaid expansion, you know, there was another slide in here that said which states were maybes and which states weren't. What we know is even states that are publicly talking about that they're not doing Medicaid expansion are privately having a lot of conversations with CMS about what the implications of expansion are, trying to use some of the numbers that we have to try to show them what it means to their states. And so if you're in one of those states, I would encourage you to keep talking with your legislators because they're continuing to have conversations. They're looking at their options. And there's a lot of really strong reports written by much wiser economists than I showing that a state is making a big mistake by not pulling this money down. So the impact is not just on you, but it's also on hospitals, private practice physicians, and the economic viability of a whole state. When you're getting 90 cents on the dollar federal funding, you pretty much need to go chase after that money. It's hard to not take that because what happens when they pay you money? You don't just take it and say, I'm a health center, yay, and off I run. You pay your staff, you pay your rent, you pay your utilities, you buy supplies, you buy things from the community, and that money goes right back into the economy in your community. What we know at HRSA, if you spend $1 on a doctor, that dollar moves around about 10 times in that community. So we think this is a good move for any given state, and we continue to try to work on that. That being the case, in those states where that's not happening, then the health centers are even more important. And so we keep saying to our PCA partners and to our state partners, for those of you that have indigent care funds, primary care funds, and things like that, it's not time for those things to go away yet. Those things need to remain until everyone has not just a place to go, but coverage and financing for a place to go. Important to note that there's no deadline for states. So, it wasn't that long ago that Arizona finally joined the Medicaid program. So I think you'll see some state that stands out there as the one that doesn't come in for a long, long time. But I do think you'll see some cohorts of states starting to come in. That program literally took about 20 years to get full penetration. I hope this one doesn't take as long. But when you see your neighbor getting coverage and you don't, it starts to be an incentive to do things like open up jobs there. In Colorado, a state that is fully expanding Medicaid, we're not having a problem attracting people to come here. If we had enough water for them, it would be better. But, this isn't being an economic drag, and it wasn't a drag on the Colorado budget. So another thing, earlier, I don't know if you saw the 20-page application. That thing's, 4 pages now? So some things have been done in the policy process that we've recognized some of the realities that you deal with. And then you're all going to see, regardless of whether Medicaid expansion occurs or not, some simplification of the enrollment categories. So in some states, there's more than 50 enrollment categories for Medicaid. The staff that do enrollment in your offices know this stuff. I don't really want to know this stuff. It gets so complicated. You have to be a very technical expert to know those categories. When we start moving down into the very small number of these, it'll be a lot easier administratively to run those things. I think Shawn covered some of the exchange stuff as well, so we're not going to do that. I think the important thing to remember is you sign up October 1st, you get services in January, and then there'll be open enrollment periods where you'll get services 90 days out from those open enrollment periods. So there is really a hot spot to try to catch people. For those of you that that are serving a lot of tribal members, Indians or Native Americans, Pacific Islanders, those individuals can come in at any time. There's no lock-in period. There's no waiting period for them. So if you are serving that population, important to know that if they choose to participate in the exchange, no requirement for them to do so, and the treaty obligations remain, they can come in at any time. So make sure you kind of catch the nuances of enrollment and finance for them. Things to know, I ask you to kind of look at California because it really shows how simple some of those things are. They have a great slide about what a gold, a silver, a platinum, and a bronze plan is. It explained it better than, I've been reading these huge policies on it, and they have a one-page slide that explains what that is. It was very good. Colorado's just about to redo their website, so you're going to see it happening here as well. But in your states that are operating marketplaces, you're going to start to see those things coming up pretty quickly. All those options will be in one place, and it was our experience in California thus far. You'll see rates went down. Most of the plans you would pay lower as an individual than the small business plans were already paying. So the idea of getting insurance companies having to put up their rates in a way that was an apples and apples comparison worked. It brought rates down. They started to recognize some efficiencies. So we think that that's going to work well. And then the idea that there's one application, whether you're applying for the marketplace insurance, or if you get in, apply for the marketplace, and we find out you're Medicaid eligible. I think that was the neat thing about California was it would flat out tell you you're going into the Medicaid program and it's confidential and nobody's going to ever see the difference, and off you go. And most people will get a break on costs. I think that's a big message that people aren't hearing. So there's two components to those individuals that have to pay could be subsidized on. Not just the premiums, but also the cost sharing will be subsidized for individuals at certain income levels. And so you need to kind of catch the subtleties of that as we go forward to make sure you're collecting those co-pays and cost shares as you go forward to make sure you're recognizing that some of them are getting that subsidized and some of them aren't. It will make your eligibility and front desk staff insane, but you deal with that if you're dealing with the insurance market already, that sometimes those are variable. But most people haven't gotten this message that there is some assistance in both those things. And for tribal members, that assistance is significantly different again. So if we're members of federally recognized tribes, make sure you're picking up on that issue as well. So kind of covered that. I'm not really going to go over this slide because it's really insane to see, but I did include it. It kind of tells you who gets covered where and what slots they fill into. For states that don't have Medicaid eligibility expansion, it is going to be kind of tough to figure out what happens to those people below the 133% of poverty when they're not going to get some of the subsidies. We think some states will, as I said, have to continue some of their indigent care programs, and some of those folks are going to be at your door, and that's why we're going to continue to fund the health centers and try to help keep you viable through that process. You know, this is not that much different from a slide that you did, but essentially one application, we determine eligibility, you figure out which one of those things you go to, and either go into Medicaid or you go into the marketplace. It really is that simple. It's really, so if you go apply to Medicaid and they figure out you're eligible for the marketplace, they'll send that data for you. If you apply to the marketplace and you're eligible for Medicaid, they'll send that data for you. So it really is going to be a no wrong door for the individuals. But one of the things that we and the folks at CMS have talked about a few times is trying to make sure we send people to the right door, because this isn't free to send people who came into maybe the wrong path to get on the right path. So do kind of try to keep aware of what Medicaid looks like and whether you should have them just apply directly to the Medicaid program so the marketplace isn't having to divert too many people. And it'll just run smoother if you're not having to run through another process. Even though you're not seeing that process, those of you that have done eligibility know every time that application has to get exchanged, there's a chance for an error. And so to try to reduce error rates, it'll help you to have a better idea whether they're going to end up. And we think the simplified requirements for eligibility, things like moving away from means testing, will make it easier for you to know which slot somebody's going into. There's a toll-free call center launching later this month, 150 languages available, so we've heard a lot of input about languages that were less than the sort of historic 10% that we've always wanted to cover. Healthcare.gov, you can web chat on there in English and Spanish right now, and they've actually been getting pretty good volume in Spanish, so that's working pretty well. And then, of course, there's going to be a lot of in-person help, including, there was a lot of talk about navigator grants and who was going to be eligible for those and should health centers go for them. And HRSA kind of didn't say anything for a little while about that. It's because we were in process of generating these additional funds, some of which came out of ACA funding that was directed at other parts of the department. Because HRSA and the secretary believed so strongly and were able to convince the administration that doing assistance at health centers was such an easy spot to do it. You were in communities, you already had uninsured people, you knew how to access the other uninsured people. That's where that $150 million came from. We're proposing July is when you're going to get the awards for that. Most of you know what the amounts are already, but there still is a process where you're having to apply to us. I talked to CMS a couple days ago. It looks like the training that you'll be required for those individuals to have to pull down that money will be available in August. And we're having some conversations at HRSA about maybe doing some pre-training. So some of that stuff is still in process. But you're going to look for August is when those folks really need to make sure they're available to take that required certification training. And it'll really just be, did you get enough hours? And they're going to put it on multiple platforms. So you'll be able to get it in multiple different ways, but mainly a web-based training is probably going to be the most convenient way to do it. Just a quick timeline. It was interesting, I was at a meeting in Wyoming, about a month ago, and they said, we've never seen this timeline. So really, this is the time we want to train you for consumer assistance. That's why people like me are out here saying, enroll, learn about this right now, so that in October you're ready. So if you're saying, well, I don't quite know everything, or maybe the executive directors know and the staff don't, the practitioners don't, the front desk people don't, this is the phase where we want to make sure we start sliding through your whole organization. So whether it's your people who are dealing with people at reception desks, we're actually building training for everybody and every level of your organization. And there's some conversations earlier this week where we're going to start doing a better job of trying to tell you, we mean for this to be a management level training. We mean this to be a practitioner level training. We mean this to be an eligibility worker, front desk worker kind of training. So we're going to start targeting stuff at your staff. And as we go into the resource piece, you're going to see us on our websites. There's already some of those resources there. So your staff can start to view some of the presentations and start to learn those things now. But I think that's really where we think you should be, aside from all the contracting issues Shawn brought up. So, what HRSA is doing around this stuff, a lot of issues around people with chronic disease. We do a lot of state calls with the HAB directors if you're participating in the Ryan White program. There's a specific website, hab.hrsa.gov/Affordable Care Act. There's some peculiarities about when you can use HAB money and when you should be using Medicaid money, when you should be using ACA marketplace money. If you're participating in that program, I really encourage you. That's our primary means of communication on that. So it's not as much webinars and speeches like this because we're having trouble getting to conferences. It's really this website. Office of Women's Health are doing some activities. The Bureau of Primary Health Care announced the $150 million and much more. So we're doing webinars, TA calls, staff education, and all the things that I was talking about. This is probably the most important thing. I'm coming here specifically to ask you to do something. And that is start having conversations with your patients. Do they know what insurance is? Do they know how it works? Do they know what you mean by copay in the insurance world as opposed to what they're paying you? Do they know what a provider network is? If they have a chronic disease, mental health or other, do they know how to look for that drug in the plans? Because not all drugs are going to cover, so they'll have deals with drug companies that in the plan that they may have first-line drugs, and that's the drug they're on, or it's not, and the insurance company may come to you as the practitioner and say, well, did you try drug B instead? Well, mental health patients don't like to change the medications they're on when they're stable. They don't. I get that. I came from a mental health background. If they know how to read those lists and look at those pharmaceutical lists beforehand, they can choose a plan that more closely meets their needs. Does it have the specialty care they need located someplace that they can get to? And, if I were you, am I in that network? So they're already getting care someplace. They should be looking for plans that are in the care, that are least disruptive of their care. Because we know if you try to move somebody from one location to another, a certain percentage of them just don't make it. So they have coverage. There's a provider there with a slot for them, and they don't make it there because they don't know how the bus line runs to that place. Or there's not a bus line that runs to that place in some of these cases. So start having those conversations with your plans. And we think that the real key are with your enrollees. And so we think the key things are what co-pays look like, what are they going to have to pay in the future? That's what they want to know. And can they get to the spots? And the drug coverage we think is crucially important. And then what's the application process going to look like? If you're in a state-run marketplace location, a lot of them are talking about doing like kiosks and things. Maybe you can get one of those in your health center, or maybe you know where one of those is, or maybe you can, a lot of this stuff is going to be done online. Maybe you can help your eligibility workers by having computers available that they can do that sign up in your lobbies and things like that. So these are the things we're looking for. Or if it's a Medicaid expansion state, can you get a county Medicaid worker in your office? That maybe it wasn't as big of a deal before because the benefit wasn't targeting the clients you happen to be seeing. But maybe it's time to do that. Or maybe, those of you who are dealing with public housing, which is a lot of you, is that public housing unit going to be an enrollment spot? And do you go advocate for that with your state? The two big things are, if you haven't put yourself on a little healthcare.gov thing, go do this. There's a lot of information that gets pushed out through there. And later, healthcare.gov is going to start sending you to the state-based marketplace or the federally operated marketplace for your state when you hit it. So when those switches start to flip in July, you go to this webpage and you're in Colorado, it's going to send you to the Covered for Colorado website. They changed their name, and so I always get it wrong. This is a little more for practitioners, but I was talking to you about presentations and little widgets to put on your websites and your emails. Marketplace.cms.gov is more for you to learn about what's happening with the marketplaces, where this stuff is coming from, and how to maneuver that. It's also a good place to ask questions. So I bet Shawn puts a question on there once a week. And then from HRSA's side, if you want to see what we're doing with the policies, how they're changing, most of this stuff is shaken out already, but a few things have to still be caught up. If somebody's eligible for both Ryan White and Medicaid, how are we going to deal with that? There's some conflicts in the statute. So you're about to see some things come out there. Changes to the 340B program policies, you're going to see those things here. So that's HRSA.gov/Affordable Care Act. So I encourage you to kind of keep asking those questions, keep moving forward. You're going to see a lot of stuff coming from us. We know that you're getting a little webinar fatigue out there in the field because the Bureau and other places are sending you a lot of things. We're really working towards streamlining those. And then the main thing I always tell everyone, so Kyle, my office manager, could say that I said it again, if you have a question about how things are working with HRSA, always ask your project officer. It amazes me that most people just exchange documents with them and make sure you're getting paid and stuff. Ask them a question. Sometimes it gets bumped to people like me in the Office of Regional Operations, but they're your real doorway to getting a bunch of technical assistance. So certainly go with them, and then our partners at NAC and your PCAs are in constant communication with HRSA. So make sure you ask those questions. The biggest mistake you can make right now is not saying, well, I have a question, but I don't think it's getting answered, and not asking somebody. So we're feverishly looking around, and every once in a while, one of you asks a question that we haven't asked internally. So we need that from you. We need to hear that information. So we make sure we develop an answer for you fast enough so that you can learn it before August and September so that you can apply it in October. So welcome to Denver. I hope you enjoyed your time here. We flipped the weather back to being good just for you. And have a safe trip home, everybody. Thanks.
Thank you so much, Mr. Gillies. And he actually has to leave to go to another meeting, but we do appreciate HRSA being here today and a very important time for you. And so our next speaker, it's my distinguished privilege to introduce Ms. Velveta Golightly-Howell, who leads the Office for Civil Rights at the U.S. Department of Health and Human Services, and she's actually responsible for the areas of Colorado, Utah, Montana, Wyoming, South Dakota, and North Dakota. So I would like to have you join and welcome Ms. Howell. Thank you.
Testing. Testing. Can you all hear me out there? Great. Good morning. It is a pleasure to meet all of you, and I want to start by thanking Dr. Webb and all of the conference planners. As Dr. Webb introduced me, my name is Velveta Golightly-Howell, and a lot of people smile and kind of chuckle and say, is that truly your name? And I say, yes, it is, and it's one that I'm proud to have. I tell people that to remember my first name, you simply need to think of the cheese product, Velveta. I am not named after that product, but it's an easy way to remember my name. So, what I am going to do once we get this slideshow started is to share some information I think and hope you'll find helpful. For some reason, the slideshow just popped off. I am technology challenged, so that explains that I wasn't pushing the right button. Okay. We are the Office for Civil Rights of the Department of Health and Human Services. We are led by Leon Rodriguez, who was the former Chief of Staff at the U.S. Justice Department under Tom Perez, who is now the Assistant AG for Civil Rights at the Justice Department and who was formerly the director of my agency, the Office for Civil Rights. We are part of the Secretary's office at HHS, and we have about 230 employees nationwide. This chart just shows you where we fall within the Office of the Secretary. Remember, HHS is huge. It's the second largest department in the federal government. Homeland Security is the only one that's larger, and that happened when it merged several organizations, including FEMA. This is an org chart of HHS, which shows you the various components of the department. And here I've shared an org chart of the Office for Civil Rights so you can see how we are broken down. And you can also see that we have 10 regional offices around the country. Mine is one of those. What is OCR responsible for? Well, we do a lot of different things, but what we actually do a lot of work in is the area of traditional civil rights, health privacy, and health security. Our missions are several. We are there to protect and promote equal access for persons with disabilities and other protected categories to those programs that are funded by HHS and other programs, including all public programs under Section 504 of the Rehabilitation Act. We are also here to promote confidentiality in medical information and to ensure that that information is secured. Now, the one thing that I wanted to share is that we have very broad-based jurisdiction. And on this slide, I've just indicated a number of different organizations over which our office would have jurisdiction. That includes health centers. Has anybody ever tried to man a microphone, a slide show clicker, and some notes? Well, that's me this morning. Okay. We have a number of regulations that we enforce, but those include regulations that prohibit discrimination based on race, color, national origin, sex, including gender orientation, religion, so on and so forth. We also enforce Title II of the Americans with Disabilities Act, which applies to public entities, and we enforce the non-discrimination provisions of the Affordable Care Act, which you've heard a lot about this morning. We do this through different means, including complaint investigations, compliance reviews, technical assistance, and the development of policy. I wanted to mention to you that insofar as technical assistance is concerned, we use it to resolve complaints and compliance reviews when a covered entity is willing to cooperate. We enter into a settlement agreement and provide technical assistance. We monitor settlement agreements using technical assistance. We also do quite a bit of outreach. Now, I talked about Section 504 and Title II of the ADA. Section 504 prohibits discrimination based on disability status by entities that receive funding from the department. Now, entities don't have to receive funding directly if you receive funding indirectly, you're going to be subject to Section 504. Title II of the Americans with Disabilities Act, otherwise known as ADA, is also a law that prohibits disability discrimination, but it applies to public entities. So any kind of state, local, or part thereof is going to be covered by Title II. Title II has a number of provisions, and one of those is called the Integration Regulation, which says that a public entity shall administer services, programs, and activities in the most integrated setting appropriate to the needs of qualified individuals with disabilities. Title II also has what's called an Reasonable Modifications Regulation. That provides that a public entity shall make reasonable modifications in policies, practices, or procedures when the modifications are necessary to avoid discrimination on the basis of disability, unless the entity can demonstrate that making the modification would fundamentally alter the nature of the service, program, or activity. This morning, I want to focus on a Supreme Court decision called Homestead v. LC. And in this court decision, the court was actually interpreting the integration regulation that I just mentioned as part of ADA. And the court's central holding is that the ADA prohibits states from unnecessarily institutionalizing persons with disabilities and from failing to serve them in the most integrated setting. In that decision, the court held that states must provide community-based services for persons with disabilities who would otherwise be entitled to institutional services when such placement is appropriate, the affected person doesn't oppose the treatment, and the placement can be reasonably accommodated, taking into account the resources available to the state and the needs of other individuals with disabilities. Homestead, the decision was actually looking at people who are already in institutions. But this slide that I have here says that although that was the focus of the court decision, subsequent court decisions have applied Homestead to individuals who are at risk of institutionalization, including those who are on long waiting lists, those who receive cuts in community services, and then they are placed at serious risk of institutionalization, as well as those who are required to first go into an institution before they'll be eligible for community support services. Homestead personally is one of those decisions that is very close to my heart, and I like to tell people that although you may think, well, it doesn't apply to me, it has nothing to do with what my organization is doing, it might actually have something to do with you and your family members, either now or in the future. For example, my mother, who's 89 years old, is living at home, but she's able to live at home because she has care that we're providing for her. Otherwise, she would be institutionalized. That happens to people every day. Now, I mentioned that people are at serious risk of institutionalization in certain circumstances. But I wanted to just read to you a statement that was issued by the Justice Department in its Homestead enforcement. The question that DOJ received is, do the ADA and Homestead apply to persons at serious risk of segregation. And DOJ answered, yes, the ADA and the Homestead decision extend to persons at serious risk of institutionalization or segregation and are not limited to individuals currently in institutional or other segregated settings. Individuals need not wait until the harm of institutionalization or segregation occurs or is imminent. For example, a plaintiff could show sufficient risk of institutionalization to constitute an Homestead violation if the public entity's failure to provide community services or its cuts to such services will likely cause a decline in health, safety, or welfare that would lead to the individual's eventual placement in an institution. A lot of times the question becomes, what is institutionalization and what is fundamental alteration? I wanted to just share with you that, as I mentioned, the Supreme Court in Homestead cited to the ADA Title II Reasonable Modification Regulation, which requires public entities to make reasonable modifications to avoid disability discrimination unless those modifications would entail a fundamental alteration of their service, program, or activity. When we talk about fundamental alteration, there is a defense that is actually referred to using that concept. And what the court has determined is that it could be considered a fundamental alteration of a state's program and therefore unreasonable to modify a state law if a comprehensive, effectively working plan for placing persons with disabilities in less restrictive settings is developed and a waiting list is developed that moves at a reasonable pace that is not controlled by the state's efforts to keep institutions fully populated. We move on to the discussion of that defense, and courts have actually differed in their opinions about what is required. In a case called Frederick L. v. Department of Public Welfare out of the Third Circuit, and in particular Pennsylvania, there was a class action where people with mental illnesses in institutions said that they should not be there and that the state was not working hard enough to get them into community settings. There was a decision made on behalf of the state at the trial court level, and then the case was appealed to the appeals court. And the appeals court held that a state can't assert the fundamental alteration defense without a plan, and a plan that specified a time frame or target date for placement in a community setting, the appropriate number of persons to be discharged during each time period, eligibility standards for community-based services, and a general description of the collaboration needed. DOJ has issued certain guidance on Homestead plans. And what DOJ, the Department of Justice, has said is that to raise a fundamental alteration defense, a public entity must first show that it has developed a comprehensive, effectively working Homestead plan that meets the specified standards. The public entity must also prove that it is implementing the plan in order to avail itself of the fundamental alteration defense. A public entity that cannot show that it has and is implementing a working plan will not be able to prove that it is already making sufficient progress in complying with the integration mandate and that the requested relief would so disrupt the implementation of the plan as to cause a fundamental alteration. There's been a lot of litigation by the Department of Justice on Homestead, and courts around the country have looked at cases brought under the integration provision of the ADA. And states oftentimes have come back and said, well, it's too financially draining for us states to be able to develop these plans, get to the point where waiting lists are moving effectively, and getting people out of institutional settings. And there was a case out of Oklahoma called Fisher v. Oklahoma, where the appeals court spoke directly to that defense of it costing too much to move a person from an institution into the community, and said that the fact that Oklahoma has a fiscal problem by itself doesn't lead to an automatic conclusion that preservation of unlimited medically necessary prescription benefits for participants in the Advantage program will result in a fundamental alteration. If every alteration in a program or service that required the outlay of funds were tantamount to a fundamental alteration, the ADA's integration mandate would be hollow indeed. So the court, in essence, in this particular case, which involved a prescription plan that was optional, said to the state, just because you're claiming it costs too much money will not be enough to sustain a defense in this Homestead case. And the court was very specific to say that you don't just look at the immediate costs that would be involved, but rather you have to look at the state's whole budget. And in looking at the state's whole budget, oftentimes it is very difficult for states to meet the fundamental alteration defense. I wanted to talk about the 10th anniversary of the Homestead decision. The decision came out on June 22nd of 1999. So in June of 2009, the Obama administration paid particular attention to what was happening on the community integration front. And the president established what is referred to as the Year of Community Living. And President Obama said, Americans with disabilities have a fundamental right to choose to live independently. Since Homestead was decided, I wanted to note that many people have been able to transition out of institutions, but there are still a lot on waiting lists and who are going on to waiting lists who want to live in the community and can live in the community with supports and services. And that's where interagency coordination comes into play. The same year as the Obama administration deemed it the Year of Community Living, the HHS Secretary Sebelius, was charged with making sure integration was occurring and that there was coordination. And this obligation also extended to HUD, Housing and Urban Development. So a lot of times people say, well, what are you guys in the federal government doing to ensure that we have the resources needed to get people out of institutions into community settings? That's where OCR has decided, in conjunction with an interagency council that was created by Secretary Sebelius, to focus on coordinated efforts and resources. And I wanted to let you know that on the council that has been created within HHS, there are a number of organizations represented, including the Administration for Community Living, the Centers for Medicare and Medicaid Services, HRSA. Patrick just spoke to you about HRSA this morning, and others. What is OCR in particular doing? What are the other departments doing? Well, to advance Homestead, OCR has been working with the U.S. Department of Justice, the U.S. Housing and Urban Development Department, the Centers for Medicare and Medicaid Services, the Administration for Community Living, which was formerly known as the Administration on Aging, the Substance Abuse and Mental Health Services Administration. We've come together and provided a number of different supports, but what OCR does in particular is we collaborate with states and other stakeholders in the development of Homestead plans. Giving you an example, just a couple weeks ago, I, along with a representative of the Justice Department and a representative of our legal team, presented training for the Medicaid office staff here in Colorado. And in addition to that staff, we were joined by staff from the Office of Housing for Colorado and the Office for Mental Health. And right now, the state is going back to the drawing board because it had developed 3 Homestead plans in about 2001, 2002. But it has found that those plans do not work in today's environment, and rather than having 3 plans that affect 3 separate populations, it is going to have 1 plan, and it has brought in a consultant to help with the development of that plan. We also have sent letters to the state Medicaid directors, and we just don't send letters. We talk directly to state Medicaid directors. Last summer, the Region 8 Medicaid directors met here in Colorado, and I was able to present on Homestead for those directors. The Administration for Community Living directors met here in Colorado. I was able to present for them as well on Homestead. So we're getting the word out and doing this technical assistance. HHS and HUD have come up with what is referred to generally as money follows the person's grants. That is where people actually get to decide what their care will be, and they direct the funds that are issued for their care as opposed to the government being involved. Colorado has a very progressive money follows the grant process in place right now. As I mentioned, we do technical assistance, and we've worked with other agencies now for a number of years, but I wanted to share that last September, we had what was called an Homestead Policy Academy in Columbia, Maryland. I almost said South Dakota, Columbia, Maryland. And that was an academy that invited representatives from 5 states. There were over 35 states, if I remember correctly, that applied to be part of the academy, but only 5 were selected. Colorado was one of those 5. That was a great academy because it brought people together to talk about what they're doing in their respective states on Homestead planning, and it gave them a chance to meet with people from the Justice Department, OCR, and other organizations to talk about what their plans needed to encompass. The Samsa, Substance Abuse Mental Health Services Administration, as an outcome of the Policy Academy, created a TA plan, which it has just begun implementing just a couple weeks ago. The Samsa representative from Colorado, along with a number of people from different areas of the country, presented what I believe was the very first technical assistance event to be held in the country, and that one went extremely well. They presented to staff at institutions here in Colorado, including those at Fort Logan and Pueblo. Those are the only two institutions we have here in Colorado. HUD and HHS have also begun what we refer to as capacity building multi-state meetings. And those are held throughout the country. The first was held in Dallas. It brought together about 4 states. The second one was held in Seattle. It brought together a number of states. We have one that is planned for Denver later this year, and there are a couple of others that are planned. But by the time those events are concluded, we would have reached all of these states. Now, one thing that we're particularly proud of in the state of Colorado is called the Colorado Homestead Housing Coalition. And it is one of only 2 that I know exist in the country today. But that coalition, which we created in the spring of 2011, brought together a number of partners, including public housing authorities, and we sat down and began working together on issues that come up and that we can prevent, that we can work through together. Just yesterday, we had a meeting with ADAPT, and ADAPT had a number of questions and issues that it needed to bring to our attention. ADAPT is part of our coalition now, as are other disability rights organizations. But the meeting yesterday gave us insight into some questions and issues that we will need to be discussing and addressing. The coalition itself has had a number of successes. I've named a few here. They include resolution of an identification issue, which ADAPT brought to us, where public housing authorities were requiring there to be particular identification of citizenship status presented before persons were allowed to move from nursing homes into communities. Well, we took that on, and we found that it was really a simplistic issue because HUD had already addressed the issue and had said, you don't need this kind of documentation. If you're in a nursing home, that documentation is already going to exist, so we will pull it from the system. And so we were able to resolve that issue. Also, we've been able to get public housing authorities to set aside additional vouchers, preference vouchers for persons with disabilities to get them out of the institutions. We have constantly received information, done training on, and provided information that is of interest to the coalition members. And the last bullet I have here just says that we serve as a collaborative model. In fact, HUD, HHS, the Department of Justice have all given kudos to this coalition and said that they would like to see more replicated throughout the country. I mentioned the multi-state meetings that we've had in Dallas and Seattle and the one that's coming up in Colorado. On the Homestead horizon, we are more than likely going to see issues surrounding integrated community living, which relates to supported employment, sheltered workshops, meaningful integrated activities. That is one of the biggest issues right now because people had been placed in these employment positions where they may have made $1 an hour or something, and they were just doing work that really wasn't of very much benefit to anyone. And there was a problem there because they weren't being integrated into employment in community kinds of organizations. Also, looking at subpopulations, like people who are young. That is one of the issues we're looking at, because right now, you may not believe it, but we have very young people who are living in nursing homes because their families have been told this is the only place they can go. You're going to see more complaints involving Homestead. The Department of Justice, if you were to go online now, would see that there are a lot of complaints and cases out there in courts that revolve around this issue. We have a number within the Office for Civil Rights as well. Now I just have some resources for you. I will not read these resources. You can flip through them at your own time and leisure. I wanted to point out, however, that we have included a few handouts for you all, one of which is shown here in the slideshow that specifically relates to Homestead. So when you have a chance, please read it. It has a number of links that you'll be able to reference. This is our website with more information on Homestead. This is my contact information. And this is the general information for HHS. And I really want to thank you for your patience this morning. It was extremely difficult to see the screen, my paper with glasses, and handle the clicker, but you've been extremely patient. I'll be around for a few minutes after this. If you have any questions, I'd love to answer them. And again, I want to thank Dr. Webb and the planning body.
Thank you very much.